Good afternoon, everyone. So I'm going to be discussing fertility preservation in adolescents and young adults with cancer this afternoon. As Dr. Effinger referred to, probably most patients in some way possibly have a risk for infertility, and it's been known for quite some time that that risk exists. The focus on preserving fertility, however, is something that is somewhat more recent, and it really comes together from a confluence of factors. Importantly is just improved survival, such that actually having biologic children, quality of life, has become an area of concern to survivors. We're able to draw upon the experiences of the general population and their interest in having improved reproductive technologies, such that there actually are interventions that now exist to be able to preserve fertility. And then patient advocates have really taken this on as a very important area for themselves. Again, Dr. Effinger referenced how important this issue is to patients. And we hear, anecdotally and in studies that patients will say, well, I didn't really get so much information about this. I didn't hear about it. Even just talking about it would have really made me feel better. And I think, Rutho, that some of the data that you presented is really very encouraging about maybe that more of this information is beginning to happen in the field. So the importance of this has been recognized now nationally. So organizations including ASCO, the American Society of Reproductive Medicine, and the National Comprehensive Cancer Network have all come out with guidelines really stating what an integral part of cancer treatment for AYA is in terms of fertility preservation, that it's something that needs to be discussed, and that referrals, when they're going to be made, need to be made in a timely fashion. So to review the issues at hand, I want to go a little bit into pathophysiology for both males and females, just to kind of set the stage for what fertility preservation options exist for each of these groups, and then to discuss some gaps and challenges for where we can move forward. So I'm going to start with males. In the world of fertility preservation, males are a little less complicated. This may or may not recapitulate your view of the world, but there it is. At least in fertility preservation, it is so. So in terms of reproductive pathophysiology, the prepubertal testes contain germ cells, and these germ cells, under the influence of reproductive hormones at the start of puberty, have two tasks. One is they mature into sperm cells. That process takes about 70 days, but they also, very importantly, have a self-renewal pathway. And so these germ cells continue to repopulate, such that in a healthy male, they would be considered to be fertile really from puberty until the time of death. There are a variety of impacts that cancer treatment has on male fertility. The depletion of germ cells is really one of the most common impacts for males. Again, Dr. Effinger referred to the exposures that are important, so chemotherapy, radiation therapy. Obviously, the surgical removal of testes is going to impact fertility. It is very common for males to experience temporary azoospermia or infertility during or after therapy, and that's due to destruction both of maturing cells, but also to a relative depletion of stem cells. So the maturation process can resume post-therapy. When that happens is really quite different from individual to individual. It can take months to years, but in many instances, even in someone who is infertile, has azoospermia following therapy, ultimately we will be able to be fertile. Permanent azoospermia really comes about when there's such a sufficient depletion of the germ cells that there's no possibility of that maturation process resuming. You can also have damage to the ductal system such that it interferes with ejaculation. The pelvic nerves can also be damaged during surgeries. That can impact functionally. And damage to the pituitary, either through the location of a tumor or treatment directed towards the pituitary, can affect the overall hormone regulation that can affect fertility. So sperm banking, I don't know, there wasn't really a better image. So that seemed to really capture the is a very common, very well-established method for fertility preservation. It is considered non-experimental. The most common method is to have a male masturbate to ejaculation, to do a semen analysis, to assess whether their viable sperm exists. than to cryopreserve the sperm and store it for future use. Again, this has been very well established, and multiple studies have really shown that it can be done with thought in adolescent populations and in young adult populations. Probably the easiest way to go about it is the utilization of an outpatient sperm bank, where you actually send a patient so they're able to attend to whatever concurrent paperwork or laboratory analysis is necessary. It's also possible to do it outpatient within a home setting if that's more comfortable for someone, where as long as you have the proper specimen collection, that's a possibility. And then frequently it's necessary for sperm banking to occur in an inpatient setting if somebody is really too sick to leave the hospital, or there are tests that are being done at the same time. So that is very possible, but again, it requires coordination. I'll talk a little bit more about that. There are definitely some challenges related to sperm banking. One is just the impact of disease, and so it's certainly been documented that in individuals with testicular cancer or with Hodgkin's disease, sometimes they will produce a specimen and there won't be any viable sperm, and it's the effects to some degree of the disease process itself. There are a number of issues related to timing. There's often a lot of pressure to begin therapy. People feel very uncomfortable with delaying the start of therapy to allow sperm banking. And while it is true that the recommended process is really to have abstinence for 48 hours and then to produce a number of specimens over the course of a number of days to kind of maximize the volume of the sperm that can be stored, it is possible to even get one specimen, and that may be sufficient for future fertility. But the bottom line is also that if sperm banking is thought of at the time at which somebody is first being worked up for a diagnosis, they may even actually have the time to produce multiple specimens. So that one of the real issues is just thinking about it, that you have to think about it at the time that diagnosis occurs. Cost can be a challenge. It's about $500 to $700, depending on where you are, to do a semen analysis. Annual storage costs are probably somewhere between $200 and $400, and so that can sometimes get in the way for individuals, although Livestrong sponsors the Sharing Hope program, which enables individuals to have discounted rates for sperm banking. I'm going to get back to costs at the very end. So this is one of those instances where when Dr. Blyer says, well, what group are you talking about? Adolescents really can provide a different set of challenges, particularly the younger adolescents, because really for them, the first task is just to make an assessment of whether they're able to masturbate to ejaculation. Have they ever talked about this with anybody? How are they going to feel if they're an inpatient about being asked to produce a sample with their mother standing outside of the room? I mean, and this is what we sort of do all of the time. And so these are a lot of considerations that really need to be taken into account. There are some religions or others with certain cultural beliefs who do not believe that masturbation without the intent of fertilization at that time is appropriate, and they may not be able to partake of sperm banking. And then there are certainly populations of patients who are just too sick to sperm bank at a given time, and so that may limit their ability to do this. In those instances, there are some other methodologies. I actually don't have a slide for this, but there's retrograde ejaculation, where there's actually, under anesthesia, you can have rectal stimulation. And if you have a catheter in the bladder, you may be able to actually get some sperm by that method. TESI is becoming more common. It's an outpatient procedure. If it's done in conjunction with another procedure like a line placement, it actually is not necessarily that much more expensive than sperm banking. So the testicular tissue is removed, they look for sperm, and then this has really become increasingly feasible because you can use the stored sperm in conjunction with intracytoplasmic sperm injection, where really you're just taking one sperm and introducing it into an egg to develop an embryo. So now really, much more feasible option. Testicular tissue freezing is another option that's really very highly experimentally currently. It's the only method that's available for prepubertal patients. It can be done outpatient. You're basically removing the tissue, and what you're trying to freeze are the germ cells. And the goal ultimately is going to be that you'll be able to mature these germ cells at a later point in time. But currently there have been no human births, but there are quite a number of studies that are going on doing testicular tissue freezing to try to move the science forward in the future. Gonadal shielding is very standard for individuals who are getting radiation therapy to the testes. The testes are very highly sensitive to radiation in terms of germ cell depletion. So in terms of parenthood after cancer, there is the option for natural conception. I mentioned that the timing to resumption of fertility really varies among individuals. And so, it sort of depends on how quickly it is that they are looking to start a family biologically. There is some concern about, when should somebody make an attempt, depending on what their risk for relapse is. To some degree, I think it's a discussion that needs to be had, but it's also a choice of the individual patient or couple. And a semen analysis will enable somebody to identify whether or not they have viable sperm. Assisted reproduction then is another possibility post-treatment, either if someone has bank sperm using ICSI, or TESI, the testicular tissue extraction, can be attempted post-therapy also. And at Cornell, they've actually had some very good luck with pregnancies using this methodology. And donor sperm is also an option, as well as adoption. So my thought on this has kind of evolved over time. And what I really recommend currently is that really almost any post-pubertal male who is willing or interested in sperm banking should do it. Because in the grand scheme of what we're asking them to do and what the cost is, it's really not so invasive if we have them do it at the beginning in a thoughtful manner. And that they have the option. Well, sorry, I'll go back once. When one of the reasons I really think this is that even individuals who have a lower risk for infertility, if they relapse in the period of time in which they are azoospermic from the therapy that they've just received, they won't be able to sperm bank at that point in time. So this idea, this approach certainly overshoots probably the number of individuals who need to do it. And even in general, when people look at who comes back to retrieve their sperm, the numbers are not very high. They're sort of 10 or 15%, but it's 10 or 15% of the individuals who that's how they're going to start their biologic family. And there is the option, by doing a semen analysis, to make an assessment of what, if there's viable sperm post-therapy, such that you can make a decision about not storing sperm any longer if there is viable sperm. So on to the more complicated females, even though I've used up more than 10 minutes of my time. So the pre-pubertal ovary also contains primordial germ cells that, under the influence of hormones at puberty, begin to mature. A number of follicles are in the maturation process at any time. At the beginning of a menstrual cycle, there are developing follicles. A number of follicles get called into that development at the beginning of any cycle. One egg becomes the dominant one, it becomes fertilized, and then days later it becomes implanted into the uterine wall. So the potential impact of cancer and treatment on fertility is obviously, again, if you remove the uterus or ovaries, you can have damage to the uterus, so fibrosis, vascular insufficiency, that can impact the ability for an implantation and can cause preterm loss. You can have hormonal dysregulation, again, tumors located near the pituitary, or treatment that affects the pituitary, and again, germ cell loss. So I just want to go through germ cell loss in a little bit more specifics for females. So this is what would happen in a normal female, and usually when I give this, use this slide in a group of any woman in the age of somewhere between 25 and 40, everybody's got like, by the end. So women are born with all the follicles that they will ever have. So there is no self-renewal process the way there is for males. They begin menarche somewhere in their early teens. They continue to have loss of these follicles. The loss is actually primarily due to atresia and not ovulation. So there's a great deal of loss that goes on through this time period. They reached a threshold point at which fertility really decreases in a healthy woman. This is somewhere in their mid to late 30s. And then they reach a second point, late 40s, early 50s, where they're now in menopause and they can no longer get pregnant. So we refer, and Dr. Effinger referred to these terms earlier, there is acute ovarian failure. So if this is cancer treatment and this is the depletion that's caused during that cancer treatment, someone is in acute ovarian failure if they reach this threshold immediately or shortly after their cancer therapy. By contrast, we talk about premature menopause, where you have a loss of follicles, not sufficient to put you in menopause, but sufficient to move this line to the left so that you're going to go into both diminished fertility and menopause at an earlier time. And that becomes really important when we think about what kind of fertility preservation options are available for females. So embryo cryopreservation is the most common intervention. It is very common in the general population, and so it is probably technically the one that people are most comfortable with. The first part is you get ovarian hyperstimulation. So these are multiple follicles in the ovaries. There is retrieval prior to ovulation. There's fertilization to create embryos, and then cryopreservation. There are a number of limitations. Again, if the older you are, the lower your ovarian reserve is to begin with, the less successful this intervention may be. People may also have very strong feelings about creating embryos where there's not really clarity about what's going to happen in the future. You need a partner or donor sperm. Younger patients may feel much less comfortable with this. It is very expensive. It is $10,000 to $12,000 to $15,000, and that's part A, and not, looking down the road in terms of when you then are going to implant. And then importantly also, so this actually does take more time. At a minimum, it takes about 2 weeks for this process to occur. In places that are more comfortable doing this, they now do not need to start at the beginning of a menstrual cycle to do the hormonal stimulation. That was really the more common way of doing it. And so in some instances, if someone had just completed their period, you needed to wait, an entire month to start this process. So it takes less time, but it takes at least 10 to 12 days to go through this process. And there are many diseases where, physicians are just uncomfortable saying that I'm gonna wait that long. And so that is certainly a limitation. Oocyte cryopreservation is essentially the same process, except you don't fertilize the egg. It has the advantage then, therefore, of not needing a partner or donor sperm. So very significantly in the fall, the American Society of Reproductive Medicine deemed that this is no longer an experimental procedure. This is not experimental, and so really should be something that I think in general we're thinking more about for our patients. That being said, oocytes are still somewhat more susceptible to the freeze-thaw cycle than embryos are, and so the success rates are somewhat lower. It is really just as expensive, and it takes the same amount of time in the beginning. Ovarian tissue cryopreservation is the removal of ovarian strips, freezing, and then re-implanting them later. This takes no time. It's, again, the only thing that's an option for prepubertal females. And it doesn't really cost that much, again, if you do it in conjunction with another procedure. In general, what people have done to date is that they re-implant either at the site of the ovary or in some other site so that to be under the hormonal stimulation to produce mature follicles. So again, the hope is really that ultimately there can be in vitro maturation, and I'll talk about that just one more comment later on. It is highly experimental. There is some concern that you can reintroduce cancer cells, particularly leukemia, into the ovary if you reimplant. And so in that patient population, it's really not something that is considered doable. Sorry. 12 here is in parentheses because I don't really know what the number is. I think there are lots of different articles that come out, but the main point is that this number is not more than 20 or 30 at best, and it may even be closer to sort of 12 or 15. It's really unclear when the tissue is transplanted. Is it from the ovary that was left behind? Is it from the tissue that's coming back? And so, the numbers really are not very high. And again, there is a cost associated with the storage at that point. For individuals with low stage cervical cancer, who earlier would have had their uterus removed with obvious implications. Now there are a tracheolectomy where you only remove part of the uterus, part of the uterus and part of the cervix, and so then they can actually carry a pregnancy. In terms of protecting the ovaries, there again is the gonadal shielding during therapy, radiation therapy, and ovarian transposition, where you actually remove the ovaries outside of the radiation field. There's a lot of talk on and off about gonadotropin releasing hormone agonists and antagonists. I think it gets used a lot out in the general community. I also think that there really have been no great studies that have ever shown that this is actually helpful, and in fact, it causes menopausal symptoms, and so in some ways it may actually be more problematic, but we don't have any really great studies in the end that push people one direction or another. So I think for me that fertility preservation for females post-treatment has really become an area that we need to focus on more closely. There's lots of information that some fertility is really retained after the completion of therapy. The place that we all want to know about is, what is this red line? When are you going to hit the point where you're not going to be able to become fertile anymore? But in this period of time, there are a couple of options. You could say, well, get pregnant, which is actually, I think, what a lot of oncologists tell their patients. Just have a baby before you're 30. That's what you got to do. But of course, now I think that it's really worth considering some of these fertility preserving methods in this interval, that you're beyond the cancer diagnosis, life maybe has calmed down, you might be in a different place in terms of personal relationships, and this may actually be a very good place to start thinking about doing egg and embryo freezing, because cancer patients, like, again, the rest of much of the female population in our country, may want to be delaying childbirth. There are evolving methods of trying to assess where people are on that this line. So we're looking a lot at anti-Müllerian hormone, looking at antral follicle counts, ovarian volume, to try to make some guesses, but we're really not quite there yet. So in terms of parenthood, again, the issues with natural conception are the same. It's really worth trying. Again, there's the issues of relapse. The issue of relapse is a little bit more complicated, again, in women, because if they relapse while they're pregnant, that's slightly different than if you've been the sperm contributor to a pregnancy. There was just an article that came out by Lisa Diller looking at CCSS data where that was actually very promising in terms of survivors being able to get pregnant, but it's sort of taking longer than their sibling controls. And then assisted reproduction, the ideas for this are very similar to men, thawed embryos or oocytes, IVF. There are donor oocytes, donor embryos. Surrogacy is a consideration for those individuals who perhaps have radiation therapy as part of their treatment, and maybe they're not able to carry a pregnancy to term. It might be viable for individuals who have a primary malignancy within their abdomen and require frequent follow-up scans, and so you can't expose an embryo to that, so surrogacy might be a possibility. And then there are individuals who actually other late effects from their treatment, so cardiovascular or pulmonary, may actually prevent them from getting pregnant, but they may be able to have a biologic child using a surrogate. There's lots of different laws about which states let you do that or don't let you do that. And then adoption, of course, is another possibility. Again, a couple of comments with pregnancy. I talked about the timing. There is a need to consider late effects, and so there's an increased blood volume in pregnancy in somebody who already has diminished cardiovascular function or difficulties with their pulmonary function. They may really need to be followed by a high-risk OB. PGD is up here also just to remind me that there's no data to suggest that children of cancer survivors have any increased risk of congenital abnormalities compared to the general population. But in individuals who carry a genetic disposition to cancer, pre-implantation genetic diagnosis may be a way to identify, for example, somebody who's BRCA-positive breast cancer, to identify among possible embryos if there's one that carries it or not. So my summary recommendations for the females, again, are a little bit more complicated. I think everybody deserves a discussion about it. I mean, they really need to hear what you think the possibilities are. Anybody who wants a referral to a reproductive endocrinologist should at least have a referral to have that more in-depth discussion. And then I think it's hard, I think then we all sort of come to some decision about which patients we push potentially more than others, and that's really dependent upon their age at diagnosis and their high-risk exposure. And then again, I really think that in this gender post-treatment assessment, especially if it's not done, a diagnosis should be done, and consideration of fertility preservation should be considered at that time. So just some very broad thoughts. In terms of clinical research, I really do think that still the information on who's at risk is very, very limited. It is very hard to pinpoint specific exposures with your risk of infertility, and we don't have great nomograms that sort of put together, age and exposure and past history. We know very little about what the host brings to the risk of infertility. So what else potentially about family history? What would have happened had they not had cancer? New therapies, of course, are uncharted waters. We don't know what the impact is that's going to be. We're trying to learn a lot more about estimates of fertility, particularly for women post-treatment, but these are things we're really working on. And then, of course, how do all of these factors impact decision-making for an individual? And again, particularly for females, where it's expensive and it's time-consuming and can really cause a lot of stress and anxiety in an already stressful, anxious time. In terms of basic science, I think we're far away from this, but the ability to mature germ cells to mature cells in both testicular tissue and ovarian tissue, if that happens, will be game-changing, because then that is going to be an option that does not delay treatment and really offers increased access to many people. In terms of clinical care, it's really talking about how we integrate fertility preservation into AYA care. And there are many ways to do this. I think the bottom line is there has to be a mechanism where everybody gets the information that they need. You do need institutional support for this. Even with the goal of having this be something that every person who's talking to someone who has a new diagnosis gets into their mind that I have to mention it, I still think in every place there's got to be somebody whose main focus, main job is thinking about this. And there really has to be an established referral mechanism. If somebody comes in and they say, I want a sperm bank, and you don't know where the sperm bank is, and you don't know, what kind of specimen jar it needs to go into, it's not going to happen. So all of that has to happen before, anybody is getting referred. And then finally, and I think that in terms of some of our goals here today, this is something that I really want to highlight, because I think this is something that we can really push for currently, and that's how we cover the cost of fertility preservation. So Livestrong has really been working a lot on trying to work with insurance companies and thinking about how to get insurance companies to cover fertility preservation. And the AMA just came out within the last month about a statement that says that insurance companies should cover fertility preservation in cases where the infertility is expected to occur as a result of cancer treatment. And their analogy is what happened about a decade ago or so, which is that breast reconstruction for those who have mastectomies for breast cancer is not elective surgery. It is something that is occurring because of cancer treatment, and that you cannot hold cancer survivors to the same definition of infertility, which is, having tried for X amount of time to be able to avail themselves of insurance coverage. And I think that if coverage is really able to occur, that this is going to make an enormous difference for cancer survivors. And again, I think sort of the time is right, and it's really a place where we can have some role in pushing this through. There is actually a bill in the California legislature currently that is attempting to have this covered. So really, the effort is underway. And these are Lindsay Beck's children, 2 out of 3 of them. And she just, this was something that she sort of does, and it always reminds me that to want to say, this is why we are doing this. So Lindsay Beck is the founder of Fertile Hope. She had tongue cancer and relapsed tongue cancer, and these are her children. And the reason that we talk about fertility preservation is so that cancer survivors can have pictures like this. Thank you. And some references.